So treatments for inflammatory bowel disease are divided into two. You've got medications to induce remission and medications to maintain remission, and there is a difference depending on whether or not it's Crohn's versus ulcerative colitis, and even within the broad areas, what part of the gut the Crohn's is in, the extent of the colitis, the severity of the colitis. In broad terms, the mainstay for getting patients into remission most of the time, in the first phase at least, is steroids, although patients with limited left-sided ulcerative colitis may not need steroids. They may just need a high dose of mesalamine to get them into remission. In terms of the maintenance of remission, 5-ASA medications like mesalamine are still very important aspects of how we maintain remission in ulcerative colitis. They have been proven many times over now not to have a benefit in Crohn's disease. Having said that, they could be used sometimes in a subset of patients with purely colonic Crohn's disease. They may have some use, but generally we avoid 5-ASA medications in Crohn's disease. Now, moving on from patients who fail to remit with ulcerative colitis on mesalamine, or maintenance treatments for patients with Crohn's disease, immunomodulators such as azathioprine, mercaptopurine, are still very widely used, very cheap and effective medications, which are limited somewhat by intolerance. About 1 in 4 patients we start on azathioprine or mercaptopurine will fail to tolerate the medication, either due to early adverse events such as nausea, vomiting, headaches, fatigue, things like that, or deviation in liver function tests, and leukopenia, which is one of the side effects we worry most about, and we do occasionally still see patients with a granulocytosis type pictures from azathioprine. Moving to the sort of top shelf drugs for inflammatory bowel disease, that's really where the exponential growth is at the moment. We've had infliximab, Remicade in Ireland now for about 20 years, and a lot of hospitals now are moving into the biosimilar space, which these are which have the potential for huge cost savings in the hospital setting, but there is still a little bit of uncertainty about how best to switch patients. Then on top of that, we've got adalimumab, Humira, which has been in Ireland for 10 years now, and just more recently in the last number of years we've gotten medications like Stelara, ustekinumab, and Entyvio, vedolizumab, which work on different pathways to the classic sort of anti-TNF medications of infliximab and adalimumab. Particularly Entyvio is something that's extremely promising. Takes a little bit longer to work than things like infliximab and adalimumab, but it seems to have a much better safety profile and fewer associations with infection and cancer because the agents themselves are gut specific.